We would like this morning to welcome Dr. Rosanne Leipzig, Professor and Vice Chair for Education of the Brookdale Department of Geriatrics and Palliative Medicine here at Mount Sinai, for her Grand Rounds presentation on prognostication in geriatric care. Dr. Leipzig received her MD and a PhD in human genetics from the University of Michigan. She completed her internal medicine residency training at the University of Rochester and a fellowship in clinical pharmacology at Cornell. In her career, Dr. Leipzig has focused on improving the quality and safety of care for older adults, and she has been recognized as an expert clinician, patient advocate, and educator. Please join me in welcoming Dr. Leipzig.
Hi, it's a pleasure to be here. It's always nice to play on the home court, and I'm glad to see so many people, considering how many in our department right now are out on leave with their kids. Okay, so happy holidays to everyone. I'm going to be talking about the role of prognosis in geriatric care, and before I start, I want to give credit to two of my colleagues, Jenny Latrivis and Beth Ann Scarborough, who developed some of these slides, especially the ones with the fun cartoons on them. Okay. So the objectives of today are for us to talk about the relationship between function and prognosis, and for certain very common chronic diseases, identify prognostic indicators that should put a little red flag and say, this patient's trajectory has changed. Something's different than it used to be. And then to learn some skills to aid in prognostication and in your discussions of prognosis with older adults and their families, and actually with anybody who needs that kind of discussion. So just so that we're all on the same page, medical prognostication, the definition that I'm using is the prediction of an outcome for a specific patient. So we have all of these data that refer to population health. I'm talking about the health of the person who's right in front of you. And it involves two different skills. The first is foreseeing, or formulating the prediction, and the second is foretelling, or communicating the prediction. And both are really important and difficult. So when we talk about outcomes, I divide them in two different sets. The first set are situations. So what are the outcomes of normal aging? Should I give a colonoscopy to this patient? And we'll show you that in a moment. The outcome for certain disease processes, and then the outcome for interventions. I also talk about the types of outcomes. So there's survival, and that's kind of the easiest one to get, right? You're alive or you're dead. No questions. Quality of life is another story, but that tends to be what a lot of people are very interested in. And when my patients talk to me about quality of life, they talk about, can I live independently? Can I get around on my own? And will I suffer? Those are the three big concerns. So why does this matter in the care of older adults? Because it helps them and us do better decision making. Patients and families actually want to know, and I'll show you some data on that in a moment. It helps us help them choose wisely. And I'm going to give you an example of this in a study that was done about 15, 20 years ago, looking at people with advanced dementia and their proxies over an 18-month period of time. So these were people who had very severe dementia. They were in nursing homes, 22 different nursing homes in Massachusetts. And the question was asked of the proxies at the beginning, how many of you have received prognostic information? What's going to happen to your loved one? And 1 in 5 said they had. How many of you have been counseled on the complications that accompany dementia? 1 in 3. Not very good numbers. And when they looked to see what kind of care these patients got at end of life, those whose healthcare proxies understood both the prognosis and the clinical course of advanced directives, dementia, got comfort-oriented care as opposed to hospitalization, tubes, etc. So it makes a difference. One of the things that's really important as you're thinking about prognosis, and this is particularly for normal aging, is the time to benefit. As my friend Dave Rubin says, when you're 83, we're not talking about 20 more years. Although for some people and more people we are. So you did this every day. How long does it take to benefit from aspirin for primary prevention, vitamin D to prevent falls if you believe that it does, bisphosphonates for osteoporosis, statins for whatever you're giving the statin for, prostate cancer screening, and colon cancer screening. And this is the example that I was giving you before. When you have an older patient with you, you need to think about these things. These are not things that occur immediately. These are not antibiotics. Okay, this is preventive care. And these are the data that we have for colon cancer, and this is based on the sigmoidoscopies. And you can see it takes almost 10 years or more before these lines separate. Okay? So if you're not going to be living 10 more years, you're probably going to die of something else, and you don't really have to worry about colon cancer and having another colonoscopy. And as I always say when I show the slide, I have never had a patient say, "Oh, you mean I can't have another colonoscopy?" It's actually good news. So from a prognostic historical point of view, in the 1700s, the view was avoid gloom and doom. Okay, deception is the high road. Don't tell people, don't take away hope. In 1990, surveys showed that physicians disclosed prognosis for only a third of the patients they referred to hospice. So what's the definition of being able to be referred to hospice? The physician believes you have 6 months or less to live. Okay? 60% of physicians felt they received poor training on prognostication. And my guess is that that's true for this group as well, even though it's 20 years later. And the attitude was avoidance and waiting to be asked instead of being proactive. Today, studies show that physicians would withhold prognostic estimates in 60% of patients, even if their patients insisted. And one of these studies were patients on dialysis. We give the least honest figures to those with the worst prognosis, because we can't deal with it. And 80% of our patients now want as much information as possible. Now, obviously, that's not every patient. That's not every ethnic group or cultural group. But in general, people want to know what's going on, whether it's good or bad. So this is an example of this. This is end-of-life prognosis. These are 6 different studies of that. Is that a, yeah, I got one of those, okay. So here you're seeing what the physicians estimated as survival, median survival. Here you're seeing what the actual survival was in weeks. And here you're seeing how wrong we were, okay? That we were off by up to 5 times the amount of time. We gave them 5 times longer than they actually had, all right? Because it's really hard to say. I don't think I think you have just a couple of days or weeks to live. So this is a chance for improvement, and clinical experience is really important in prognostication. Your skills can improve over time. The more patients you've seen, the more people you've done this with, the better you will get at it. But also, we now have some tools that can improve your ability to prognosticate. And if you think about it for yourself, when you see a physician and you get a diagnosis, we talk about treatment. We talk about how to diagnose it. We talk about the harms and benefits of the treatment. But what the patients really want to know is, how is this going to affect my life? Okay? They want the prognosis. So, let's start with just in general old folks, okay? And we're going to talk about median life expectancy. And median life expectancy is the age to which 50% of people will live. Okay, 50% will live to a greater age, 50% won't make it that far. So if you're 65, what is median life expectancy? 50% of people will make it to what age or more? Somebody has an opinion. 80. All right. It's actually now almost 84, which is good news for me at 67, okay. Glad to hear it. When I ask residents this, Every time I do it, there's at least one person who says 70. And I tell them they have to get out of the hospital, okay? Got to get a real life here. If you make it to 85, 50% of people who make it to 85 will make it to what age? All right. Winner. And if you make it to 100? Almost 2.5 more years. The older you are and the older you get to be, the older you will get to be, okay? And it's really important to recognize this. I mean, this is the fastest growing group in our country, are those who are over 85 and particularly those who are over 100, okay? I know the Times obits are not scientifically done. They're not a good example of what's going on. But the number of 107-year-olds and 101-year-olds and 99-year-olds is amazing in there. So the thing for you to remember is that it's not age that rules, it's function that rules. Function predicts mortality, function predicts morbidity, and quality of life. So it's really important to have a sense of what the function is of your patient. So I'm going to just give you an example of this by telling you about 3 of my patients. And this is Rose, this is Leticia, and this is Nancy, okay? So Rose, this isn't really Rose, this comes off the internet. I can't show you a picture of her, but this is Rose, and it looks a lot like her. She's 90 years old. She considers her health excellent, which is a great question to ask people. It's actually a very good predictor of what their actual health is. She has new onset hypertension because 90% of people who are 90 have hypertension. She has a really good chance of making it to 100 or more. This is Leticia. She's 78. She's had diabetes for 40 years. She has low vision from her diabetes. She has COPD. Now she's got rheumatoid arthritis on top of all of this. She's miserable. She's in pain. She's having trouble using her hands. She's depressed and she's scared. And this is Nancy, who's also just turned 90. She has mild Alzheimer's and COPD. She still lives alone. She's got a very strong social network, but her closest relative is in New Hampshire. And she has a 10-pound weight loss, decreased exercise tolerance, and more difficulty walking. And she can't really tell me what medication she's taking, although she's in charge of her own medications. So, for older adults, one size fits all doesn't work. And you need to have a way to think about prognosis for the person who's in front of you. This is one simple way that people are starting to look at this. There aren't definitions that everybody uses, but there are definitions that people do use to try and determine who's fit, who's vulnerable, and who's frail. So as we go through prognosis, I'm going to start to give you some different ways to look at it and to help you determine which of your patients are fit, vulnerable, and frail. So function rules, and as I said, there are different ways to look at this. We're going to talk about 2 single measures that you can use. We're also going to talk about frailty indices, disease trajectories, and prognostic indices. Okay. So, gait speed. Everyone, as they get older, has a slower gait speed. It's a part of life, okay? You can be a marathon walker, you still will be walking more slowly as you get older. And the variability is much greater at young old age than at old age. At old age, everybody's a lot slower. Gait speed is a good measure of life expectancy, but it's also a good measure of function. So the way you do it is you mark out 13 feet or 4 meters and you tell someone to walk that at their usual pace, okay? And if it's less than 0.6 meters per second or greater than 1 meter per second, you can divide them into people who have slow gait and people who have a fast gait, okay? The timed up and go, I'm sure you've all seen. It's where you have to get up out of a chair without using your hands. Don't make it a chair with rollers, okay? Have them walk 10 feet, turn around, and come back at their usual pace. And it's timed, and there are a billion cutoffs for this, but a very helpful one is 15 seconds or more, okay? So if they have a slow gait speed, less than 0.6 meters per second, or their timed up and go is 15 seconds or more, at 1 year, it predicts global health declines, a new difficulty in an ADL, we're talking about walking, bathing, toileting, transferring important things that you need to be able to do, and an increase in falls. Okay, so that's a very simple predictive tool to help you realize who is more likely to have a rapid decline over the next year. What's interesting is that these also predict postoperative complications, and one of the take-home messages that I'll be hitting over and over again today is that having a sense of somebody's vulnerability or frailty improves your ability to predict whether they will have a problem with surgery. And since many of us do pre-op clearances, we need to have a sense of that. So slow gait speed has been shown to be an incremental predictor of higher mortality and morbidity after cardiac surgery, and that 15 seconds or more timed up and go predicts post-op complications and 1 year mortality. So although it takes a few seconds to do a timed up and go, you get a lot of information from it. So let's talk about frailty indices, okay? And I want to make sure, again, we're all on the same page. So what is frailty? Well, many of you remember Judge Potter Stewart and his definition for when he was asked to define pornography, right? I don't have a definition, but I know it when I see it. Okay. That's good, that's helpful, but you have many patients who are frail and you may not know. So people have been trying to develop frailty indices to help us predict, okay? So what we're talking about is as you get older, you have a decrease in physiologic reserves. And in geriatrics, we tend to call that homeostasis as opposed to homeostasis, which means that you can get back to equilibrium when you're thrown off it. That's homeostasis. Homeostasis, it's harder to do it. You have a narrower window, okay? So what happens is you have diminished resiliency, you can't adapt as well, and there's an increased vulnerability to stressors. And what's really critical, and what you can see in Rose, Leticia, and Nancy, is that individuals of the same age differ in their vulnerability to these adverse outcomes. And frailty measures attempt to quantify these. So what's so bad about being frail? You'll fall, you'll have more disability, comorbid disease states, you're more likely to get delirious, have cognitive decline, iatrogenic complications. So when you prescribe things to people, they're more likely to have a bad effect from them, and social withdrawal, and of course, death. So the classic phenotype of frailty was developed by Linda Fried at Columbia, who's now the dean of the Mailman School of Public Health at Columbia. And there are 5 parts to it. This is a research definition. Most people will not use this in practice, but I'll show you something that you can use. So this is an unintentional weight loss of 10 pounds or more in the last year, a grip strength that is in the lowest 20% for your sex and BMI, reporting that everything was an effort and you couldn't get going for more than 3 days of the last week, walking speed, which is for 15 feet, which is within the lowest 20%, and low activity in terms of kilocalories, the couch potato, okay? And the way this is scored is if you have 0 or 1 of these, you're still considered robust. If you have 2 to 3, you're considered pre-frail or vulnerable. And if you have 4 to 5, you're considered frail. So these are the data that she first showed. And what we have up here are the outcomes. So people who died, first hospitalization, first fall, worsening ADL disability, and worsening mobility. And over here, we have robust, 0 to 1 on the scale, pre-frail, 2 to 3, and frail, 4 to 5. And what you can see is these are 3-year and 7-year outcomes. And whatever it is, it's increasing dependent on whether you are robust, frail, or pre-frail. So it really nicely gives you a sense of people who are at greater risk. Preoperatively, it works the same way. Okay, these are post-operative complications. Here it's very interesting. Pre-frail and frail are equally at risk for preoperative complications, for an increased length of stay, and for discharge to an assisted living after previously living at home. You know, there weren't a whole lot of these folks, which is why you've got that kind of a confidence interval. Okay? Yeah. So, oops, there we go. So this is a terrible slide, okay? But what we're looking at are 3 different indices that we use for looking at complications perioperatively. And so we have the Eagle, the Lee, and the anesthesia one, okay? And what you see here for each of them is these are the lines if you just use that scale. And this is what you get for area under the curve if you add frailty in. It increases your ability to predict complications of surgery. Okay? The Frail Scale is kind of watered down, but it works similarly. So you don't need anything extra. You don't need to know where they fit on a sex and age type of scale. F is for fatigue. I felt tired all of the time or most of the time during the past month. Resistance, difficulty walking up 10 steps alone without resting and without aids. Ambulation, any difficulty walking several hundred yards alone and without aids. Illnesses, 5 or more of the following. And loss of weight. And this is a self-report of 5% or more over the past year. And you have robust, pre-frail, and frail again. And this is, again, showing you a very similar slide to the one for Dr. Freed's frailty index, with the numbers of people who die, who get physical limitations in 5 years, increasing based on their frailty for both men and women. Okay? So one last piece on frailty. If you just want to use one thing, that timed up and go is really good, okay? And it's not sensitive. You will miss a lot of people with frailty if you just use the timed up and go. But if they're at 15 or more, they're pre-frail or frail, okay? So that's stratifying by function. How about disease trajectories for quality of life and for life expectancy? My guess is that many of you have seen these trajectories. Okay, they've been out there for a while. This is the cancer trajectory. This is function on each of these slides I'm going to show you. This is the onset of incurable cancer. And this is function, which goes pretty well until it doesn't. And usually that's about a 2-month period. Okay. So what is this one? Give me a couple of your diseases that that you deal with all the time.
Heart failure.
Heart failure, okay. Anything else? COPD, yeah, these are perfect for that. They're doing, they're not doing great, they're doing okay. Exacerbation, come into the hospital, you get them better, and they're not quite as good as they were before. And this keeps, all right, I think I have a tremor. This keeps happening until it doesn't happen. And everybody says, wait a minute, it's exactly what happened before. They were fine, and you got them out of it every time before. Why'd they die this time? Okay? It always seems sudden, even though it isn't. It's a trajectory. All right? And then there's dementia and frailty, where generally you're starting at a lower level and going down toward death. And then there's us. You go to sleep and you wake up dead, okay? So changes in disease trajectories can be very, very helpful for you and also for your patients to better understand what the future will bring. So for many disorders, there are key features that you should keep in your head that signal a change in trajectory. And this is the time to have that discussion with patients and families, okay? So end organ disease and cancer, what I'm going to show you over the next few slides are the National Hospice criteria, just so you know, because you can get people into hospice, and then the truth, okay, as to what really is, you know, a 6-month trajectory for many of these people. The cancer ones are closer than any of the others, okay? These are based mainly on impaired performance status, impaired nutritional status, and a decreased serum albumin. So that serum albumin is really important to have. And we don't always get it on the tests that we do routinely in the hospital. And it's worth getting, okay? So this, when people start having impaired performance status, they're losing a lot of weight, their albumin is down, the end is near, okay? Congestive heart failure has a bad prognosis. We all know this. It's got a, you know, half of people will die within 5 years, and the annual mortality, depending on the study you look at, is huge. And this is one of Beth Ann Scarborough's little people, okay? So if you look at the hospice guidelines, you have to be class 4 and receiving optimal treatment, and then have some of these supporting factors: ejection fraction low, symptomatic arrhythmias, history of cardiac arrest, concomitant HIV, stroke of cardiac origin, or unexplained syncope, okay? This was a study that was done a little while ago that really gave a much clearer idea of when to start thinking that somebody has 6 months or less to live with congestive heart failure, so that they are class 3 or 4 and hospitalized and have 3 or more of these clinical characteristics or lab imaging. So when it's the 4th hospitalization for your patient with CHF, start thinking about this and having conversations with the patient and the family about, do they want to come back? Do they want comfort care? What is it that they would like going forward, okay? Dementia is a huge concern for our country, and it's becoming more so, okay? So there are stages of dementia. We talked about this with the Mitchell study, and most of us just put down dementia. We don't say what stage somebody's at, and that's not really that helpful. And it certainly isn't that helpful for patients and families, okay? So what I'd like to do is just take a couple of minutes and go through the stages of dementia so you have a sense as to where people are in their trajectory. So the MMSE is what a lot of people still use, and the MOCA is somewhat comparable to it. Actually, it's a better test, but that's another story. And MCI stands for mild cognitive impairment, which means that you have an increased risk of becoming demented each year, okay? So these are the numbers that we tend to use. The time course, MCI is preclinical. You don't have any clinical, it's not affecting people's lives, so it's not a dementia. Mild, people tend to stay in this between 1 and 3 years. These are not exact, but the mild part of the disease tends to last that long. Moderate can be up to 8 years or even longer than that, and severe 6 to 12 years. It definitely is a terminal illness. It definitely decreases life expectancy, okay? That's what you need to know. So there's no functional impairment by definition for MCI. Mild are the IADLs, the instrumental activities of daily living. When you start hearing that somebody's having trouble with finances, driving, and medications, and there aren't other good reasons for it, think dementia. It's starting, okay? As it progresses, you start having trouble with gait and balance, more falls, and some of the ADLs as well. And then severe dementia, which I know you have all seen, are people who can't do their ADLs, are incontinent, have mobility impairment and dysphagia. It's a terrible disease. Cognitive changes, mild construction, language as you start, and then people start having trouble with insight, short-term memory deficits, repeating things, and poor judgment. So that means they're at risk for being at home alone. Moderate, they become disoriented to date and place, they get lost, they repeat questions. And severe, there's little intelligible output, okay? Remote memory is gone. They don't recognize family and friends. Behavioral issues, Mild starts with withdrawal, apathy, depression. Some people feel part of this is because people are realizing what's happening, okay? Moderate, the delusions, agitations, aggression, spelled wrong, restlessness and anxiety, wandering. And severe, people don't move much, have very few words and verbal outcome. And there's agitation and aggression because they don't understand what's going on and what's being done. And people start to sundown. Okay? And finally, the complications. Mild, you get trouble with drugs, adverse drug reactions because the brain is much more sensitive to medications, being old to begin with. And then with dementia or stroke or Parkinson's, any structural change in the brain, you become even more sensitive. You have, you can't live alone, falls, and then over here you get the pressure sores, the contractures, and the aspiration pneumonia. And remember, of those people who ended up with severe dementia in that study, only a third of the families had been told what to expect. Okay? So, dementia is a terminal illness. There are three things that are really helpful. When one of my patients gets pneumonia, has febrile episodes, but particularly eating difficulties, I call the family in. It's time for a new discussion. We are on a different trajectory. And these are the data that show you. This is, I can't see because I don't have my glasses on. This is pneumonia. So no pneumonia, pneumonia over 2 years in essence. No febrile episode, these are deaths. Febrile episode over 2 years. No eating difficulty, eating difficulty. So that eating difficulty is where the problem comes in. And G-tubes are not going to make a difference there. What is used for hospice is the FAST scale. You can look at all of these, but what we're really getting down to is here. There's a FAST 7A, which is, FAST 7A, which is the inability to say more than a few words, basically. And then the FAST C and beyond, where you can't ambulate without needing a person, and things just get worse from there. Okay. So the dementia hospice guidelines, for the FAST, it's a 7A, just a few words, and infection, multiple stage 3 to 4 pressure ulcers because you can't move, a persistent fever, and weight loss more than 10% in 6 months. All right? Or that you've hit a stage 7C, where you can't walk and you start not eating or anything. It just goes down. Okay? So those are ways to look at function. How about looking at life expectancy? Because people want to know, how long, doctor, how long do I have? Okay? Your favorite question. So for single diseases, we have specific scores and algorithms that have a lot to do with the actual disease, with the ejection fraction, with blood pressure, things of that nature, okay? But most older adults have more than one disease. So how do we prognosticate for them? And we can do it by function, as we talked about, with the timed up and go, the gait speed, the frailty, or there are now prognostic indices, and in particular something called e-prognosis. So how many of you have heard of e-prognosis? Okay, it's really helpful. It has two different versions. One version is on your phone, and they keep tweaking that, so I'm not sure what the current version is. The one on the computer looks like this, and it asks, this is put out by the University of California at San Francisco. It asks, where is your patient? Because the algorithms differ depending on where your patient is. It shows you how good each algorithm is. This was a JAMA paper several years ago, so it gives you that information. One of these has to do with hospitalization, how people do after hospitalization. So would it surprise you to know that 30 to 40% of older people, 65 and older, lose one or more basic ADLs at discharge compared with pre-admission? 2 weeks pre-admission, okay? They can't eat, they can't walk. They came in with CHF or cellulitis or COPD, and they leave not being able to walk or eat or bathe. And only 25 to 40%, and 25 to 40% are still impaired 3 months later, and 20% are readmitted within 30 days. This is a very complex slide. Let me just show it to you quickly. These are people who left the hospital without losing an ADL. These are people who left the hospital losing an ADL. This is 1 month later, 3 months, 6 months, and 12 months. So a third are below their baseline, or back at baseline in 1 month. This percentage, almost 50%, 50% are still in a decline, and 13% are dead. At the end of a year, a third still are at their baseline, have gotten back to baseline, but 40% are dead, okay? So patients discharged with a new ADL disability who didn't recover their function by 1 month more unlikely to recover by 1 year, and the 1-year mortality is quite high. This is stuff that we do in the hospital. We cause these things to happen. Oftentimes it's not because of the disease that they have. It's how we care for our patients. So, Mr. Walter is an 80-year-old man. He's independent in his ADLs. He has CKD, creatinine of 3.2 on admission, albumin of 2.9, and he's hospitalized with a pneumonia. His respiratory status gets better over the course of his hospitalization, but his hospital course is complicated by delirium, which leads to functional decline. At discharge, he's dependent in transferring, toileting, and bathing, okay? What's the probability that he'll die in the year following his hospitalization? 10%? 20%? 35%? Okay. 50%? All right. 65%? Nobody. So here is one of these algorithms in ePrognosis. It asks what the this is specifically for people at discharge from hospital, and it's been validated. What's your patient's biologic status? Upon discharge, does your patient need help from others in any of these ADLs? Okay. And then 3 things which clearly increase mortality, okay, congestive heart failure, metastatic cancer, and kidney disease. And then what is your patient's admission albumin, which, as I told you, is a major marker of function and of life expectancy, okay? And this comes to 6 points, and what you can see here, 7 points, I'm sorry, is greater than 6 points, a 64% mortality, okay? Now, you know, this isn't for everybody, but it's really to recognize just what the prognosis is for some of the patients we think we fixed because we got rid of their CHF, COPD, cellulitis, okay? Mr. N is an 82-year-old male nursing home resident. He's been in the nursing home for a year. Oops, where'd he go? He has Alzheimer's and hypertension. He was recently hospitalized with sepsis in the setting of an aspiration pneumonia. He's dependent in all of his ADLs, so you can tell me what stage of Alzheimer's he is. Sits up in a chair most of the day. He occasionally smiles, and he speaks minimally. Okay. You fix him. He leaves. What's the probability that in the next 6 months he'll die? 10%? 20%? I hope not to make you therapeutic nihilists. 35%? 50? 65. Everybody's at 65. Remember, this is for 6 months, not a year, so a little bit of a trick. You can see here what goes into this scale. And again, we're talking mainly about symptoms, function. Is your patient bedbound most of the day? Does your patient have significant oral intake? Okay. This is for nursing home patients. And the Mitchell index tells us that this patient has about a 40% 6-month risk of mortality. Okay? So again, we feel good, we got them through everything. But what's going to happen next? So we've got the data, and I'd like to spend just a few minutes talking about how do we have that conversation, all right? I'm sure if you've seen anyone from palliative care give a talk, you've seen the slide. Okay? So why don't we talk about it? It's not part of our daily routine. It requires us to step back from our daily tasks. It requires time. It doesn't require as much time as some people think it does, and that time is now paid for, okay, in the new Medicare regs, but it does take time. We're ambivalent about this. We don't like being wrong, and this is not hard science, okay? We are going to be wrong a fair amount of the time, and we're giving bad news, which never feels good. So when we talk about prognosis, we can talk about end of life. I just want to remind you, the prognosis of a serious illness and prognosis for treatment decisions. All of those really are pieces of prognosis we need to take into account. So I love this line. This is Bob Arnold's. An effective discussion about prognosis is not giving a pill of information. And I think this is the biggest mistake I see people give. When they're having the conversation, they tell everything. They get into the weeds, okay? And they talk about what's gone on in their brain to try and get to this place. And what that does is totally overwhelm the person who's hearing this for the first time. It's a first conversation. It's about assessing exactly what the patient or the family want to know, attending to their specific concerns, attending to their emotions, which tends to be the hardest thing. You may have someone scream at you. You may have somebody burst out into tears. These are hard, okay? And it's really helpful to have a framework, some language and phrases at your fingertips. So let me give you a few of those, okay? Get the proper setting. Make sure it's private. It's comfortable. Sit down. Do not have this conversation standing up. Turn off or forward your pager or your cell phone. Anything else can wait for a few minutes. And don't do it on your way out the door. And I oftentimes recall when I was a fellow at Cornell, a resident standing at the door while I was with a patient saying, by the way, do you want to be a DNR? Okay. Not the way to do it. Assess where they are. What do they understand? What's their conceptualization of what's been happening here? What have the doctors told you about your or your wife's condition at this point? What's your understanding of the current medical situation? Make sure you're all on the same page before you get going. What's the effect of the illness on their lives? What things are the hardest for you to do at this time? What's changed the most for you with this illness? Understand what's getting to them. Some people it's, what do you mean, doc? I'm going to die. That's what's the matter, okay? Other people is, I'm not going to get to my kid's graduation, or, you know, other things that they had planned for their lives. I'm not going to have a retirement. Do a medical review and summary, but do it in the big picture, okay? A few sentences. Use the word dying if it's appropriate. All right? Make sure they understand what you're saying. Do not do an organ by organ medical review, okay? You will get nowhere because you'll just get caught in the weeds with that. Avoid jargon, okay? Use English. Answer their questions. What I say to my patients when the aspiration occurs is often when your father eats, some of the food or water goes into his lungs. This is a sign that his dementia has progressed from moderate to severe, and we've entered a different phase of the illness. I'm afraid I have some bad news. I wish things were different. Based on what you've told me and what I see, I believe your mother is dying. When you discuss prognosis, don't say 3 days, okay? A month. Use a range. Although I can't give you an exact time given your illness and condition, I believe you have hours to days, weeks to months. This is an average. Some people live longer, some live shorter. And then I often say, I may be wrong. And I hope I'm wrong, but I think we should act thinking this way and get things in order and talk about them, okay? Give the best, worst, and most likely scenarios. So this is something that a surgeon out in Minnesota did, which I just think is marvelous. And she does high-risk thoracic surgery procedures. And she made this diagram and has the following discussion. This is the variability and in time if you have surgery. And this is, she doesn't say if we do nothing, she says if we do supportive care, all right? So most likely, all right, you'll be in the ICU for 2 to 6 weeks, and you will die in 2 to 3 months. So you'll spend half of that time in the ICU. The best case is the surgery is extremely long. You'll be in the ICU for 1 to 3 weeks, and then you'll be in subacute rehab, and you'll do much better. You'll do well. In fact, we may even cure you, depending on what it is. The worst case, it's a long surgery, you have complications, and you die in the ICU, unable to talk to your family because you're intubated. With supportive care, most likely your pain will be controlled, but you'll be groggy. You'll have some time for your family to get together. The best case is that you'll have time to say goodbye, your pain will be controlled, and you'll be able to be at home. And the worst case is that time is short and death is imminent. Okay? Giving them really a sense of what are the options here. What kind of reactions do we get? The first thing you need to do is give them a chance to think about what you just said, because it's a lot of information. Prepare for those common reactions. Conflict, denial, grief, despair. What did you do to my mother? Those sorts of things. Respond empathically to those emotions. Name the emotion. It really helps. I mean, I've actually said to patients and families, you know, in certain situations, you seem really angry about what I just told you. Can you tell me more about that? Okay? You look shocked. Can you tell me what you're thinking? You appear angry. What in particular is upsetting you? Understand the emotion. I can only imagine how scary, difficult, overwhelming this must be for you. Explore the emotional state. Tell me more is a great line. Tell me more about how this is affecting you. So helpful language. Ask them, what do you know about what's happening medically and what your loved one would want? Okay, remember what we're dealing here is with substitute judgment oftentimes. The I wish statement is very helpful. Hope for the best, plan for the worst. Hours to days, weeks to months, and tell me more. And use silence, it's really helpful at times. So in summary, patients and families value prognostic information. It helps them make better medical decisions. Medical prognostication is not an exact science, but evidence-based data helps. It helps us provide useful information to patients and families because they have to do something, and they have to have some sense of what to do. And foreseeing and foretelling are skills that can be learned and you can improve. So, thank you very much.
Thank you. Knowing about the closeness to the end of life would be enhanced if we knew about the parents of the patient, excluding those parents who were hit by automobiles or other rapid, unexpected deaths. But in general, there's a good genetic control to the end of life. And if we ask the question about the parent, we'd have greater insight. The other thing is, too bad we don't yet have a biological test of cell replication because of the famous Hayflick phenomenon, which you know is linked to everyone having about 50 cellular reproductions within their body. It's possible, though I don't think it's ever been studied. It wouldn't be so bad if our medical center studied this, that toward the end of one's days, the predicted number of replications that remain between where the patient is at and the end point, which is 50 replications maximum, would give us a creatinine-like test as to the prognosis. Thank you.
Okay, thank you for your comments. I'm not sure I would agree that the genetics and how patients' parents died would give us insight into how they're going to die. I think it depends on if they have the same disorders. You know, for people with Alzheimer's, perhaps that's true. But for many other people, you know, what causes them to die could be very different than their parents. So, and also I think, you know, having a biologic test of how long somebody has to live would have positive and negatives to it for everyone. It's kind of like genetic testing as far as I'm concerned. Barbara?
That was really great. I loved it. Thank you. I just wanted to make a comment that when you do this, it really helps reduce malpractice suits, because it's that shock element in that
That's a
fourth
good point.
hospitalization that, you know, how come she died now?
Right. Right. I agree. Yes.
Please.
Can you speak to the idea of what we could do differently to prevent the decline after hospitalizations? Is there any data that that home hospitalization reduces that decline?
So the question is, what could we do to decrease the decline after hospitalization? The decline actually occurs during hospitalization. So it needs to start with a different mindset about how we care for people who are ill within the hospital. Getting them out of bed, you know, bed rest is good for dead people and a couple of others. That's about it. You get decreases in PO2, you get pressure ulcers, all of those things. You lose muscle mass, keeping them up, walking around. Mobility is extremely important, and actually at our hospital we now have a number of interventions to try and improve mobility while you are in the hospital. And those things have been shown to make a difference. Will hospital at home make a difference? We're looking at it, right? Hopefully it will. Certainly in terms of some of the iatrogenic things that occur within hospital, they may be less likely to occur in your own home. So just, you know, my example would be if you get a cold in the hospital, you get an x-ray, you get cultured, you may get antibiotics. At home, you'll take a Tylenol, you know, you'll use steam. It's a different world. So I think, you know, there is that opportunity with hospital at home. Yeah.
Great. Let's thank Dr. Leipzig for her talk.